Welcome to the MedEvidence podcast. This episode is a rebroadcast from a live MedEvidence presentation.
So, Steve, I'm really excited about our time together here. So you're a newbie.
Yeah. Thank you so much for having me. It's an honor and a pleasure to be here today to talk with you guys and have this conversation.
Yeah. So Steve is an allergy immunologist. First of all, I'm gonna give you a little bit of a hard time as a new guest. This is your initiation to the fraternity. So I know that Steve made a lot of A's in college and medical school, but you didn't have to put them all in your title there. F-A-A-A-A-A. What the heck does that stand for with all those A's?
Yeah, so the first one, the F followed by 4 A's and I, is a fellow of the American Academy of Allergy, Asthma, and Immunology.
Wow.
And then the following one stands for a fellow of the American College of Allergy, Asthma, and Immunology. And so these are two kind of research and educational groups that you have to be a practicing allergy and immunology physician for at least 5 years and be in good standing, do continuing medical education credits. So it's kind of a higher standard than just being board certified.
Yeah, you're making me feel inadequate. I only have 2 A's in my initials, and you have all these A's, so I guess it speaks for itself. So anyhow, we're going to talk about asthma, and we always like to remind the audience that you may think it's a free lunch, but it really isn't. And in fact, you got to kind of work for your lunch here, and part of that is getting information back from the audience. So we like to do these audience participation questions, and one, get a sense for what the audience knows, and also have some entertaining discussion around these questions. So let's start with this one. Just a little bit of a geography lesson and a lesson of awareness is, which is the most challenging city in the United States to live with asthma? Interesting, challenging city. Obviously, asthma patients have a lot of challenges that you can educate us on. Is it Allentown, Pennsylvania? By the way, if you come from any of these places, it's okay to scream and say, "Hey, Allentown!" So feel free to speak up. This is definitely audience participation. Is it B, Rochester, New York? C, Detroit, Michigan? All right, there we go. Go Detroit. D, Springfield, Massachusetts? Or E, Philadelphia, Pennsylvania? Yeah, so it's an interesting question. So this is probably not the right slide deck, Sharon, but Allentown and Philadelphia are neck and neck. So you can see here the most challenging cities. These are the asthma capitals of the world for 2024, and maybe you can talk about why some of these places may be, quote, considered the most challenging cities versus the least challenging cities.
Yeah, if you look at the most challenging cities here compared to the least challenging, we notice a lot of these more challenging places are closer to major bodies of water. You guys see that? So asthma, top triggers would be a respiratory infection followed by allergy, right? And so allergy is mainly driven by pollens of trees, grasses, weeds, mold. And so all of those things need water, need higher amounts of relative humidity. Additionally, dust mite is a top allergen in the U.S., and they require a higher amount of relative humidity to exist. And so you kind of notice the red versus the green being more further removed from larger bodies of water.
And yeah, it's really interesting. You can see the map is all the red places are closer to water, and that's a great point. I didn't know that, so that's fascinating. And the more green areas are more internal in the mountains, I guess. It's less challenging in the mountains compared to at sea level. Yeah. How does Jacksonville stack up?
Yeah, I think Jacksonville's a pretty tough spot. You see Lakeland on there as number 7. I'm looking at these major cities will kind of fluctuate head-to-head, coastal cities, but I know Jacksonville, North Florida has been on this list before historically, and maybe on this list in the future.
So if you had to guess, we'd be closer to Allentown versus Des Moines. Okay.
Yeah.
So just for everybody's knowledge. So we may not have broken into the top 10 this year, but we still have a chance for next year.
True. Yeah.
All righty. So let's start getting into some of the facts about asthma.
Yeah, so asthma, there's a lot of misconceptions about asthma. Most people think about asthma as this person in their mind that had this disease as a young child or as an adult, somebody who's constantly always using inhalers. Asthma is really a gradient of disease. I think about comparing asthma to the term automobile. So inside automobile, there are cars, trucks, vans, SUVs, blue ones, green ones, purple ones. Inside asthma, there are people who have very persistent, very aggressive disease that's happening all the time and constantly throughout the day. Then there's people who may have symptoms really just every few years, a little bit of coughing and wheezing if they have an episode of asthmatic bronchitis. And so if you look at asthma, yes, it's a common, chronic, heterogeneous disease that causes the airways to become inflamed. That inflammation results in constriction, and then the symptoms of coughing, wheezing, and shortness of breath. So there really are no cures for asthma. It's just a manner of, can we kind of help control the symptoms, help control the natural history of the disease. And really the best way to manage this is through avoidance of triggers. Can we avoid respiratory viruses or illnesses? Can we avoid allergens? And to take preventative medications if we can. So.
Now, is asthma the same as COPD, which is a common term? Help people understand that a little bit more.
Great question. Yeah, great question. So asthma is separate from COPD. Asthma is an intrinsic inflammatory process, whereas COPD, oftentimes we have to have exposure with either cigarette smoke or smoke of some sort, whether it's wood-burning smoke, etc., over an amount of time. Most experts would say about a 40-pack year history to have COPD would be required.
So reflecting some chronic damage to the lungs.
Yes.
That'd be the big difference,
yes.
I guess.
Yeah.
Okay. Well, tell us, how do you diagnose asthma?
Yeah, so there's a lot of different tools that we use for the diagnostics of asthma. First off, we want to talk to the patient. Some of the hallmark features that people will describe as coughing, wheezing, shortness of breath. One of our main tools as physicians and as healthcare practitioners is to use our stethoscope. We'll auscultate the chest. Do we hear expiratory wheezing? And sometimes it's very bad inspiratory wheezing as well through physical exam.
Yeah, so wheezing is the key term.
Yeah, wheezing is definitely a key term.
Is all wheezing asthma, or is some wheezing for a different reason?
Yeah, great question. There are many disease states that can wheeze, whether it's upper airway or lower airway obstructive processes aside from asthma. COPD can wheeze as well, that we kind of touched on. But so wheezing is part of the game, but not the whole thing per se. We utilize lung function tests many times to diagnose asthma via spirometry. That's a test where we have people breathe through a machine that measures how much you can breathe out in a flow state at 1 second all the way through 6 seconds, breathing out upon expiration, then breathing in upon inspiration. It helps us to see those numbers based on age-matched controls, etc. So.
Yeah. Now, when we were in medical school, the TV show Saint Elsewhere was very popular. It's probably way before your time. Who heard of Saint Elsewhere in the audience? Okay, you see more people my age out there. Anyhow, so one of the things we used to do in my medical school was to pick on the show to find mistakes that they made.
Yeah.
And so this may be an example of that. So there's an X-ray there. And do you need an X-ray to diagnose asthma?
You actually don't. Yeah. That's a common misconception. There are features on X-ray that can be seen if somebody's having an asthma exacerbation, such as hyperinflated lungs or bronchial tissue inflammation can sometimes be seen on X-rays. But more often than not, asthma remains unseen on X-ray and on CAT scan many times, especially if somebody is currently asymptomatic. But yeah, very, very common misconception.
Right.
So
you can have a completely normal chest X-ray and still have asthma.
true statement.
Yeah.
Yeah, true statement.
Yeah. The other thing we used to do back in the St. Elsewhere days is to make sure they put the X-rays up correctly. So this is a little ambiguous because usually you want the heart shadow on the left side.
Yeah.
Now he's kind of looking, he or she, I don't know if it's a he or she, but he or she is kind of looking at the X-ray, so you don't know if it's appropriate for that person's perspective or it's appropriate for the audience. But my question, big question is, why is this person wearing just one glove?
It's a great question. Great question. Not certain about that one.
I can't think of, well, maybe we can think of procedures where you'd only be wearing one glove, but hopefully not in the operating room.
Yeah, certainly.
Okay. So back to the audience work. We're going to try to identify the groups that are at the highest risk for having asthma. So curious to see what people think. Which ethnic group in the U.S. has the highest rate of asthma? White Caucasian, Puerto Rican, Southeast Asian, Native American, or Black Americans? Okay, we'll do one by one. Who thinks it's White Caucasian? Okay. Who thinks it's Puerto Rican? Who thinks it's Southeast Asian? Who thinks it's Native Americans? Okay. Who thinks it's Black Americans? Okay. Who voted twice? Okay. Now, I saw one hand in the back of the room that got it correct, but I happen to know she's also the one that made up the slide, so I think that's probably cheating. So Puerto Ricans have the highest rate. Any good reason for that?
Yeah, it's somewhat interesting. There's a lot of theories on why. The short and sweet answer, and why I'd maybe point back to the first part of our presentation. If you look at Puerto Rico, what is it surrounded by? Yeah. And if you look at the cities that have a higher prevalence and incidence of asthma and severe asthma, those places were also kind of near water, right? And so that would make sense.
And then socioeconomics is also what? Are there some details about that we should know?
Yeah, certain groups have higher risk factors for certain allergens that will provoke asthma. Specifically that comes to mind, dust mite, mold, and cockroach allergy are higher among individuals who live in inner cities and a little bit lower socioeconomic status.
Mm-hmm.
So
I see.
Yeah.
So I was at risk for asthma when I was living in my 400 square foot apartment in Manhattan that had more crawling creatures than you can imagine. Those were all risk factors for asthma.
Yeah.
That's amazing. I got through that without it. How about kids versus adults in asthma? You want to comment on that?
Yeah, we generally wait until about age 6 to diagnose asthma. Prior to that, it's treated very similarly. There's a condition called reactive airways disease, but then you can kind of make the diagnosis of asthma at age 6. And a lot of the treatments for pediatric or child patients do mirror the adult patients as well. So,
if you haven't had asthma and then at age, say, 60, you develop wheezing, is it asthma or is it something else?
Yeah, it's a great question. Classically, if we look at individuals who develop asthma, many times it is earlier on in life, childhood years, teenage years, 20s, 30s. There's also many diagnoses that are made 40s, 50s, 60s, and beyond. I mean, it can happen at almost any point in our life. Age, there's really no specific, hey, if you get past here, you're good. It can happen at any point. So
interesting. So let's talk about some of the risk factors.
Yeah, looking at this list, this is a really nice list. Poverty, and so having poor access to health care can certainly worsen asthma if you do have asthma. Kind of dovetailing with that, lack of health insurance. If you can't get your medicines, can't see a healthcare practitioner or provider, it makes asthma more challenging to deal with. Exposure to air pollution, certainly. If you think about it, this somewhat makes sense to all of us in this room. If you're sitting on the back of my truck with me and I turn on the engine, dealing in those or breathing in those fumes can be very harmful, very caustic to the lungs, and cause exacerbations. And certainly there's a higher incidence in major cities with smog, such as LA. Poor indoor air quality. We know that there's a higher risk of things like dust mite and mold allergy indoors that can provoke asthma with poor indoor air quality. Pollen allergy. If you look at individuals who have asthma under age 18, about 80% of them have some sort of aeroallergen, and the vast majority is pollen allergy. And then if we look at adults over age 18 who do have asthma, over 60% of them have allergic sensitization to trees, grasses, weeds, etc., among the other allergens. Certainly smoking or inhaling things that are not great to go in our lungs can worsen and crescendo the progression of asthma or result in asthmatic processes worsening. And lack of access to specialists who can treat and manage asthma can worsen.
That's a super interesting comment. So, someone can look at that skeptically and say, wasn't that a commercial that was put in by the Allergist Society to promote their business? But I think there's maybe another element, and correct me if I'm wrong, but if you have more specialists in the area, there's just more awareness of the condition and ways to mitigate the factors that lead to the problem in the first place.
No, you're 100% right.
Yeah.
I would agree with that.
Yeah, it's so interesting. So you mentioned Los Angeles as being a place where there may be a lot of pollution and have some exacerbation of lung disease because of that. They also have a lot of plastic surgeons in LA. And I would imagine that there's a lot more discussion at cocktail parties about plastic surgery in LA than in Jacksonville or Puerto Rico, for that matter.
Yeah.
So all these things can have influence on how diseases present themselves in a community. And I guess there's a couple other bullet points. Asthma quick relief medicine use. You want to comment on that?
Yeah, so there's some clinical studies indicating that if somebody's using a short-acting bronchodilator on a repeated basis in a very short circumstance or short period, that's been associated with worsening asthma. So.
Okay. All right. So let's talk a little bit about the management of asthma in general terms. I guess there are a number of guidelines that have come out.
Yeah, so again, asthma is a very heterogeneous disease where many people have different types of asthma. One of the main things we like to do with asthma is to figure out what type somebody has. Is it mild? Is it moderate? Is it severe? And once we figure that out based on symptoms and medication use and lung function testing, we also like to figure out, are you allergic or not allergic? And inside allergy, are there specific therapies that may be more tailored towards your type of asthma versus the next person's type of asthma? So it's really trying to personalize the management strategy depending on what may be driving the asthma.
So this is interesting, genomic profiling. That's an interesting concept. Do you actually do gene studies in people to help guide treatment, or is that more aspirational?
I think at this point it's still aspirational. It's not the standard of care, but we're hoping that can be the case in the future.
Mm-hmm. And help people understand what a biomarker is and how that would potentially drive the treatment.
Yeah, great question. Great question. If you look at a lot of the newer therapies that tend to work quite well for asthma, they're very specific in nature. For example, people who have allergic asthma, there are certain tailored therapies that we know may work better or worse depending on how high a blood level of a certain protein or cell is in their body. The same thing with other types of non-allergic asthma, such as eosinophilic asthma.
Yeah, and we had a learning session here maybe 6 or 8 months ago about eosinophils.
Yeah.
And so, is anybody here for the eosinophil talk? No, you guys missed that one? But that's a type of white blood cell that's involved in allergic reactions. and that would be an example of a biomarker, something that we can measure that gives us a sense for how severe the disease is.
Sure.
So is that something you would get routinely for patients you're treating, or not necessarily?
Yeah, so looking at people who have eosinophilic asthma, there are a couple different medications that will do things like reduce the amount of eosinophils in the body by causing an apoptosis or a suicide signal to the eosinophils. Again, asthma is an inflammatory process, and if this is eosinophilic inflammation, and we have a weapon that will get at just the eosinophils, it's very exacting with very little collateral damage to the rest of the body, and it can really help those patients. There's also eosinophilic asthma medications that will help to inhibit the growth of the eosinophils by cutting off some of their growth factors or things that feed the asthma. So.
Yeah, and one of the things we learned at our session months ago was that people who have eosinophilic asthma may also have eosinophilic esophagitis.
Certainly.
Or eosinophilic gastritis.
Yeah.
So once the eosinophils get activated, it can infect other organs, not just the lungs.
You're right. Yeah, it can be a kind of multi-organ or a systemic disease.
Okay. So let's talk about some of the treatments more specifically.
Yeah, inhaled corticosteroids have for decades been the standard of care for more persistent asthma patients. So these medications in particular have been shown to reduce inflammation in the lungs that drives asthma and bronchoconstriction, and hence they improve lung function over time. They decrease exacerbations, and they also decrease the amount of injected or oral steroids people get. And so we talk about systemic steroids, we're talking about an injection of a steroid intramuscularly, or taking an oral medication and swallowing it, going into the gastrointestinal system and ultimately into the bloodstream, as opposed to an inhaled steroid acting only locally in the lungs. So,
yeah. So again, just in terms of the details of the picture, you see a mom trying to help her child use the inhaler. Is that a challenge, or?
Yeah, it can be. Certain individuals will have problems with inhalers and coordination, but there are tools that we can use, such as a spacer. And so this is a chamber you can put on the end of the inhaler, pump the medicine into that spacer chamber, and then kind of inhale the medicine at your leisure to make it a little bit easier.
Yeah. Yeah, the other thing I would say is that the child's, I think, will be a future dentist, since she seems to be taking a keen interest in her mom's mouth and teeth. All right, so getting into other treatments for asthma.
Yeah, so kind of starting off here, we'd alluded to these biologic therapies with the anti-IL-5 therapies. These are directed at the eosinophils. And again, eosinophilic asthma can be allergic or non-allergic in nature. Then we go to the next section, the anti-IgE or omalizumab. That's a biologic therapy directed exclusively at allergic asthma. So people who have very pollen or mold or dust mite-driven asthma, it can offer huge relief. And this was kind of the first medication in this class. It's about 21 years old at this point. We have also other therapies, the interleukin-4, interleukin-13 receptor blockers that also improve asthma as well through several other mechanisms. The benefits here, again, is they're very targeted, very focused. There's less kind of systemic or collateral damage by these medicines. They reduce exacerbations, improve quality of life, improve lung function. So.
Yeah, and for the nerdy people in the audience, and I think there may be a couple, interleukins are these proteins that circulate that amplify the inflammatory reaction.
Exactly.
Yeah.
Yeah. We also look here at small molecule therapies like montelukast, the leukotriene receptor antagonist, or the phosphodiesterase 4 inhibitors can be of benefit to their oral, and they have a quick onset of action, which is very nice for patients.
Cool. And these are very commonly used, all these. Would you say your average patient is on this, or just on steroids, or has it kind of break down in your practice?
Yeah, probably 70% of my patients in my clinic I see do have asthma, and I have patients on all of these medicines, and I use almost all these medicines every day as part of the arrows in the quiver or tools in the toolbox that we use to combat asthma with. So.
All right, so now monoclonal antibodies. Wow, tell us about that. I guess the latest and greatest.
Yeah, so this is a really interesting category here. Again, this is growing. It started with this medication on your left, omalizumab, also known as Xolair. So that targets IgE, or the allergic antibody in the bloodstream. And it's used for allergic, moderate to persistent, severe asthma. And it's used as an injection every 2 to 4 weeks, and it's dosed based on weight and then the IgE level in the bloodstream. So these next three, mepolizumab, benralizumab, and resilizumab, those are all fighting eosinophilic asthma. They're FDA approved, kind of as mentioned, 6 and then up to 18 and over. They're for this moderate to severe persistent asthma group for people who have mainly eosinophilic driven asthma, and they're used, again, subcutaneously for mepolizumab, benralizumab, and then intravenously for resilizumab every, between 4 and 8 weeks. Moving over here, dupilumab, that one blocks some of these chemical signals on the receptor of interleukin 4, interleukin 13. This is for patients, you don't have to have a specific eosinophilic or allergic subtype. It tends to work it more broadly in this communication cascade of different cells that provoke asthma. And very similarly with tezepelumab, all moderate to severe persistent asthma patients, you don't have to be just allergic or have an eosinophilic subtype. It tends to work in almost everybody. So.
Now, are there certain go-tos that are more commonly used by allergists versus the others, or are they all pretty much equally used?
Yeah, that's a great question. If you look, for example, at omalizumab, there's FDA approval for allergic asthma, for chronic rhinosinusitis with nasal polyps, for food allergy, and also for chronic idiopathic urticaria. And so those 4 disease states I see all in my clinic. And a lot of times if somebody has one, they may have another. And so if we can kind of do 2 things at once with one medication, or to kill 2 birds with 1 stone, we tend to kind of gravitate towards that medication. Dr. Koren, you'd alluded to different eosinophilic diseases like eosinophilic esophagitis. And so if somebody is having eosinophilic esophagitis plus eosinophilic asthma, we may gravitate more towards one of these anti-eosinophilic medications. Dupilumab is extremely effective in atopic dermatitis or eczema as well as asthma. And so many times we'll see somebody who has allergic skin disease, eczema, as well as asthma. And so we may pick dupilumab, so on and so forth. And so tezepelumab, this is a newer medication, so it has less FDA-approved indications, but it is quite effective for asthma, and I do anticipate more FDA-approved indications coming soon for that drug.
All right. And if you want to impress your friends at a cocktail party or a gathering, and you see a drug and it ends with MAB, you can say confidently that that's a monoclonal antibody.
Yeah.
So that's part of the nomenclature. And if it says UMAB, UMAB, it's a human monoclonal antibody.
Yeah.
So that really impressed people. Say, I know this is a human monoclonal antibody. And they'll say, how do you know it? And you'll say, I can't tell you. Come to the lectures. Okay, so back to the audience questions. Which of the following are considered triggers for asthma? Is it A, boring lectures? I hope nobody answers that question A. Is it B, nagging spouses? Is it C, waiting in line? Is it D, dad jokes? Or is it E, Dr. Dorman will tell us? We heard a B out there? E and B, okay, all right. Yeah, so nagging spouses is a punchline we've used on multiple occasions here in this setting. And so it's sort of an inside joke between me and the audience, really. So we appreciate that. But I think I'm going to go with E in this case.
Yeah, so triggers for asthma, these are all really nice, not a comprehensive list, but very close to it. Indoor triggers, dust mites, danders, pollen, cigarette smoke. Outdoor triggers, we'd alluded to air pollution, places with a lot of, smog, et cetera, like Los Angeles. Very interesting here, cold air. If you look at the classic feature, or the classic test that we use now to prove or disprove asthma, it's a test called a methacholine challenge or a mannitol challenge. So before that test was developed, to prove you had asthma, if you wanted to be in the Olympics or be excluded for the military, they would use cold air inhalation. So imagine if you have asthma, they're going to take you into a freezer and make you breathe in really hard, and you're going to have an asthma attack.
Wow.
Either you do or you don't, but that's a very classic trigger. Physical triggers, some people will have exercise-induced asthma. Naturally, if your asthma is poorly controlled, increasing your heart rate, increasing your ventilation will increase your asthma symptoms, but sometimes just exercise alone can be a trigger for certain individuals. And stress. And so there may be something to that nagging spouse thing that was alluded to earlier. Psychosocial stress has been shown to be a trigger for asthma. I did a clinical study over 10 years ago with, we kind of partnered with a psychiatry group. We took people who had asthma and we put them in an MRI machine and showed them one of two videos. The first video was kind of like a Caribbean beachside scene, really no waves, very peaceful. The other video was of an emergent heart surgery procedure, very stressful, very bloody. And while we were having people watch these videos in the MRI machine, we scanned their brain, and we're looking at different centers of their brain, either parts of the brain that activate with relaxation or lack of stress versus very stressed centers of the brain. And you could guess which group of people watching which video had more asthma attacks. It was the people who were watching that cardiac surgery, that emergent, very stressful video. They had more stress centers in their brain, anger, fear, fight and flight, and more asthma inhaler use while in the MRI machine versus this Caribbean beachside scene. So it's been shown in other studies as well, but I like that one because I was participating in that one. Food can be a trigger for some people as well. We talk about sulfites or food additives. Sometimes just more common than that would be reflux. Having a little bit of reflux spilling down and aspirating in the lungs can provoke asthma. The number one trigger, kind of towards the bottom here, is respiratory infections. And so something like, we talked about these vaccines earlier, flu, COVID vaccines. We really want to get those because those things are killers and people have asthma. Something like the common cold can really flare asthmatics. So we have to take that seriously. Then weather changes, hot to cold, cold to hot, less humid to more humid can really interfere with, the pathophysiology of asthma in the lungs for people.
So I have a real burning question here. I don't see anywhere on the slide that it says a white dog chewing on a rope as a trigger for asthma. So why is that picture on this? Is there something I'm missing?
Yeah, so people can be allergic to their animals. It's very interesting. If you look at, like in my clinic on a pretty much daily basis, we do allergy skin testing or try to define whether somebody is or is not allergic to animals. And so dog is one of these common animals that people can be allergic to. But dog can also have a secondary allergy in that they bring the pollens of trees, grasses, weeds indoor on their coats. And so you can have the primary dog allergy when you're petting your beautiful pet, but also that can, get the pollen on it as well, provoking the asthma. So
interesting. Okay, so obviously one of our points of connection is that we both run clinical trials and we both support how valuable they are for the community. And we like to remind people is that for those of you who have never participated in a clinical trial, it may seem scary, a daunting thing. And in fact, when you do surveys of the general population, both in the United States and in Europe, you find that only 30 to 50% of people show significant interest in participating in a clinical trial. But interestingly, if you survey people who have done a trial and ask them, would you do it again, 97% of people said they would do another trial. And at our center, it's 99%.
I believe that.
So the question is, what is it about clinical trials that makes people really comfortable and actually want to do them after they're exposed?
Yeah, I think there's a number of reasons. People get treated really well. Like, for example, in an asthma trial, you're seen by the board-certified allergist who's interested in you and in your disease state specifically. And then you may be seen by the pulmonologist, and you get seen at a very high frequency, and so we watch you very, very closely. And so I would argue that the patients who are in clinical trials probably receive the best care.
Yeah. So my mentor during medical school was a very famous cardiologist named Eugene Braunwald. And I was reminded of this little anecdote yesterday that Eugene would say that he wants to be in the placebo group in a trial when he grows up, because even if you're in the placebo group, you do so much better than you would do otherwise.
Yeah.
And it's true, because you just get very close attention, a lot of care, and we often identify other issues that are very, very helpful for the overall healthcare needs of the patients.
Yeah.
So with that in mind, maybe we should get into a little bit of the specifics that you may be involved with.
Yeah, so we have a new clinical trial for one of these monoclonal antibody therapies, so one of these very specific anti-inflammatory asthma therapies that's not injected intravenously or subcutaneously, but actually inhaled. So we know this molecule works already on an injected basis, and so we're trying to figure out whether this is going to work for an inhaled version of this medication as well. And so we're very excited about it. Very, very excited.
Is it enrolling now?
Coming up. Yeah, I think next week is when we start.
Okay, so it's going to start. So for those of you out there that have asthma or know somebody who has asthma, it's a really nice opportunity for people to get a medicine that they may not otherwise get in any other way.
Yeah.
And again, this concept is to avoid having to use injectable therapies. So all those monoclonal antibodies that we talked to you about are usually given through injection. And not everybody likes that. So this will be an alternative to get the same benefit of the injection, but using a different means of administration.
Yeah.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.